I'm shocked about the relative amount of talk compared to actual progress. And for somebody that comes from the world that I've come through, it is quite surprising how people can talk for so long and so frequently with so little actual progress. And it's very frustrating. And I guess part of the issue is because it's about money at the end of the day. And this goes back to why I think we need something like a global health and finance board, because we need to have policymakers not just occasionally focused on it when something happens to fall in a minister's in tray, but it needs to be part of their DNA.
Sometimes people say, well, I don't want to use those data because I don't trust the quality of the data. My point is that if the data are not good enough for surveillance, they are also not good enough for patient care decisions. So by collecting poor quality data, that helps you to understand and give feedback and improve the quality of the data. I do recommend collecting poor quality data. Do not publish it as surveillance. Do not publish it for treatment guidelines, but collect the poor quality data with the aim of improving the capacity through feedback, and then you can monitor the improvement over time.
I think it's incredibly crucial to have local ownership of data interpretation and tools that enable local priorities to be put into practice. Now, there's clearly top-down and bottom-up approaches where sequences can be submitted, but that doesn't give any value to the local data generator. And it really needs to be about extracting the information from the data, linking it to epidemiological locally, that then encourages the submission of information upwards in that chain.
What is it we need to set the agenda? It's not just awareness, it's trying to build coalitions outside the medical community, because right now the medical community is driving the agenda forward and also sort of defining the agenda, framing AMR as a health issue. But I think in order to really get our footing in the sort of global political agenda, we need to sort of begin to build bridges to other, you can say the public, to other NGOs, to lobbyists that are much more flexible and much more knowledgeable about how to actually put issues on the political agenda, because that's not the forte of health expert, I would argue.
But one thing that I would, say that from our analysis, it promotes this question of, are we wanting to protect people or to protect medicines? A warning I would put out is that, let's be careful not to shift our entire kind of effort towards just saving the medicines. The reason we're saving medicines is still for the same end, which is to protect people and to provide the best quality care.
We do have our first estimates, and we need to use this data, this evidence, to really move into action. We need to have a continuous quality improvement. We know that the data that we have in the GRAND project is probably the tip of the iceberg, and that there's much more data available, but we need more collaboration to make that data available.
We all can support collaboration by building greater trust, being more clear about our intentions, seeing partnerships and not silos, through greater transparency and seeking out the yes and avoiding the no's. Through all of these key points, I think will enable the industry to work more and work better and more constructively with government partners, with academic partners, and with other funding organizations. And think about how we can improve the way in which we work together so that we're meeting the needs of the patient.
And so our vision is still, one system that serves all. And I think that we would really like to do more about empowering the low and middle income countries, because that's been a last focus point for us. And our guiding principle is cross-sector, cross-domain, and open source interaction with the rest of the world. We had a hard time in our analysis to find strong associations between AMU and what we measure as AMR. We do find it is significant, but the other contributing factors are so much more, important. So if I should invest, I would actually invest more in sanitation than I would invest in reducing AMU.
What we first need is like sort of increasing international participation in this sort of big platform to try to get better insights in terms of the situation. It's really about developing a network of people who want to contribute data to sort of strengthen the global evidence, principally to create a reliable baseline for the future. Because we can only measure the progress if we have sort of a well-established baseline. And so for me, the idea would be really to build a network of collaborators like that we can support financially.
I think the kind of the advantage of viruses is that there's a lot of surveillance data available with which to train the models, and it seems to be less common for antibiotic resistance. And the results that we had for tuberculosis were only possible because of private data set owned by a large government that was able to train that we used to train those models. But in terms of public data sets, there's some resources, but I don't think the sequence complexity is enough.
So like it'd be nice if there was like a global sort of consortium that could curate all of this existing like human this like human clinical toxicity data sets and disseminate it to people who are doing drug discovery programs, right? And then we could be in a better position to potentially train models that could predict with some reasonable accuracy whether some new molecule is likely to display some form of human toxicity when it goes into a patient. You know what I mean?
Finally, basically, what are the key applications of artificial intelligence that facilitate that help facilitate and national policymakers that they should be exploring now? Touching on Satya's point, how do we communicate findings to policymakers? How do we highlight the limitations and strengths? What are some of the biggest areas where some of these things could be applied in the next 5 years?